Thank you everyone and welcome to our webinar. And for us it's a pleasure to have one of our EAPC groups here to run the webinar. So I would like to thank to the reference group Public Health and Palliative Care, and Oicom is here to on behalf of that group. I would like to remind everyone that this webinar is recorded, so please keep your the cameras off, and use the Q&A session, as you can see at the bottom of the screen, and you can do the questions whatever you want, and because at the final we will have a panel discussion as well. And I welcome you to join and interact with the participants and all members using our chat. And I would like to invite you to put your name and the country or place that you are right now. So welcome everyone, and Oicom, up to you.
Thank you very much, Carla. I will do a very short introduction, welcoming you on behalf of the reference group Public Health Palliative Care of the EAPC. So while I'll try to share some slides, giving you a bit of an overview of what it is that we do as a reference group. So our aims are to promote and improve palliative care via public health approaches, and to develop a network of researchers and organizations that are interested or involved in public health and palliative care. And to address those aims, we do a number of activities as a reference group. I would say that we are a very active reference group. And one of those main activities includes the webinars, like the webinar that we are having today. And you can see that we are covering a range of topics and approaches within the public health and palliative care domain. Some of our past webinars, as you can see, and we organize about 2 webinars every year, cover community actions, traditional epidemiology approaches. And today we have one on quality of service ascertainment, equity, and using service redesign as an approach for that. We also do a number of other activities, and one of the activities that I would particularly like to flag now is that we just released the output of a collective effort of the reference group, where we identified in this EAPC white paper the priorities for public health palliative care research in the coming decades. So you can find that paper in Palliative Medicine, just released. We do a number of other activities, and we also would like to welcome you to the themed sessions that we are organizing at the EAPC conference in Prague, where we will also, like usually, organize an open meeting where we can have a discussion and a knowledge exchange about the different activities that each of you are doing. So we really hope to welcome you in those sessions. Also warmly recommended, register to our newsletter. You can see the QR code there, and then you'll get twice a year an overview of all the activities and interesting output that we are creating. We also organize international research seminars every 2 years, and a concept of a summer school oriented at research methods in this domain, and I would like to invite you to the upcoming research seminar of this EAPC reference group, which will be organized with the Uniclinic in Cologne in Germany, and I think it is well in advance that we are advertising this, but which will take place in March next year. If you are interested, this activity is happening every 2 years. If you are interested to have one of those activities in your city, feel free to contact us, and we'll discuss the organization of the next seminar with you. Also, flagging the conference, Public Health Palliative Care International Conference in Taiwan, to which this reference group also organizes a pre-conference academy, or in this case, we call it an autumn school, because technically it's no longer the summer. So an autumn school really oriented at developing methodological expertise and skills. So with that said, I would like to give the word to my colleague, member of the reference group, Alan Keller here, to introduce this webinar.
Hello, everybody. I'm Alan Kelleher. I'm the professor in end-of-life care at Northumbria University in the UK, and it's my job to introduce very quickly the theme of today's webinar and to introduce the key speakers. So I think when we think about services redesign, we think of 5 or 6 elements of services redesign, and services redesign is one strategy in public health palliative care, along with community development or compassionate communities, social ecology or compassionate cities, public education or end-of-life literacy or death literacy, and social marketing, promoting the idea of health and well-being in end-of-life care. And services redesign is one of those, part of the arsenal, if you like, part of the practice methodologies within public health palliative care, along with, of course, the usual things like health policy and civic policy development. When we think about services redesign, we think about how we change services. We change how services are delivered. We also think about changing services by moving them away from a solely problem-based approach to an approach that also emphasizes health and well-being. Thirdly, I think we redesign services to change the goals of the service, if you like, and that's really about making sure that health and social services aren't solely problem-based, that they do integrate the idea of health and well-being, something which remains a challenge in palliative and end-of-life care. Services redesign also incorporates the idea of adding new services or adding new activities that positively alter the effectiveness of an existing service. So it's not just changing the service by rearranging what's existing, but also sometimes it also includes adding activities or adding additional services that improve that service. Sometimes services redesign also involves changing the management or the steer of the service by making them more community or patient focused. And that plays into the other major function when we think about services redesign, which is changing health and social care services from a one-way delivery system to a partnership. So sometimes when we talk about services redesign, we're also talking about literally changing the structure of the management. And so some services are delivered not just by and controlled just by the health and social care professionals, but also controlled and managed by members of the community or patient groups. So these are the ways in which we think about services redesign in public health. And today we've got 3 colleagues who are going to give us their theoretical and practice examples of services redesign in the service of public health palliative care. The first speaker is Bee Sim, and Bee Sim is the executive director of the Singapore Hospice Council, obviously in Singapore, and The next speaker will be Noor Hisham Ma'in, who is the group lead for palliative care at the NUHS, the National University Health System, also from Singapore today. We have 2 Singaporeans speaking today. And finally, we have Emma Hodges, who I've known for many years, who is the Director of Public Health Palliative Care UK. And after that, we'll open it up for general discussion. Each of our speakers will have about 20 minutes to showcase their understanding and their practice examples of services redesign. And we will begin with Be Here. Be Here. Thank you.
Thank you, Prof. Alan. I'll be covering how we use advocacy as a catalyst to scale up compassion into action in Singapore. So perhaps I can trouble Carla to share the slides.
Yes, I'm doing it now.
Thank you.
Oh, sorry about that. The wrong one.
Okay. So as Prof. Alan has introduced, I'm Bee Hia, Executive Director of Singapore Hospice Council. And today we talk about how we move advocacy into a movement. Next one, please. So for us, similarly with everyone else in palliative care, I think we all face similar challenges. Rapidly aging population, 1 in 4 Singaporeans will be above 65 years old by 2030. We're now a super aged society. Referrals are late. Median period is about 21 days. For cancer patients, it's about 31 days. Non-cancer about 9 days. It remains very highly medicalized. Specialist capacity is affected. Yeah, and primary care is really not confident. And definitely across the world, I think there's this cultural taboo about not talking about death and dying. Next one. So how did we move from advocacy to movement? We really look at, next one, Carla. Yeah, we talk about how we demedicalize death and dying and making palliative care everyone's business. Primarily, we secured the commitment of the fraternity and the board and the leadership to move towards public health as an approach towards palliative care. Next one. So we started to look at Compassionate Community Singapore as an approach, and we decided to redesign the entire palliative care ecosystem. It is still work in progress. We have just launched it only last year in October. So it is led by Singapore Hospice Council, which cuts across the 3 health clusters serving Singapore's population. It cuts across institutions, it cuts across settings from community to acute hospitals to community hospitals. And we play the role of a thought leader and advocate. And that's why we can garner the community together. We look at tools and frameworks. So we have created a user guide and template charters for organizations to use. And we really focus on the everyday acts of care, loss, dying, grief, and bereavement. As Compassionate Communities, SG, we do, as a charity, we don't have money. We don't have that much money. We look at really about networking and connecting and maximizing current assets. And that we look at how we provide support in terms of expertise and network for 4 main pillars: knowledge, care, grief and bereavement, and social programs. And of course, very importantly, is to engage the sector, identifying priority sectors, like, for example, active aging centers located in the community, and engagement of leaders who can implement change. So advocacy reshaped and enhanced ecosystem of no one dying or grieving alone. Next one. And I will share some examples of how we did the change over the last 2 years. So first, change from services to shared responsibilities, and it's really about active mobilization and sustained partnerships. So in the past, care primarily remains very medicalized, specialist-centric. We are in that transition. Institutions are very much left on its own, and communications and engagement primarily is one way, is targeted at the general population. It's just simply one tier. So what we did was we adopted a change of multi-prong, multi-tier. We begin to differentiate our engagement in terms of communications and how we engage and do outreach in terms of general population. Second category, we have healthcare professionals, in particular healthcare professionals not providing palliative care, multipliers like community workers and volunteers, and definitely leaders who are the change makers who can implement change from within an organization. So the results was really an increase in partnerships from our usual 25 HAC member organizations 2 years ago to now more than 100 valued partners across sectors. We have now about 137 valued partners, including institutes of higher learning, universities, polytechnics, social service agencies, active aging centers, faith-based organizations like mosques, temples, churches, and general practitioners who are family doctors in private practice in Singapore. And what we see, the next slide will capture how we marked out and flagged out our notes of contact and accessibility for palliative care information by the population. So next slide, Carla. So here we mapped out, this is a Singapore map, and we started to track and where our community signposts were. These are signposts where you have volunteer staff who are trained in general information on palliative care, and they can signpost a case to and accelerate support to the family and the patient. So it includes active aging centers, social service centers, and also general practitioner clinics. And where Singapore Hospice Council is located within Singapore itself. Next one. Then the second thing that we did was, from talking about death and dying, we shifted our messaging towards live well to live well. And that really opens up the conversations and awareness of palliative care services. So in 2014, Lane Foundation had a survey done, and the survey showed 50% have talked about death and dying to their loved ones, but only one third comfortable talking about death and dying. Outreach efforts were very ad hoc, very random, as and when. It wasn't structured, it wasn't strategized, and it shows a duplication and a lack of synergy amongst partners. The change that we implemented was for Singapore Hospice Council to play the leader's role and to curate signature events like Live Well Festival, Hack Care YOLO, hackathon to hack the care system, you only live once, for full-time students, Winds of Compassion using community art of 10,000 pinwheels for people to write down their messages. So these curated signature events allow us to pool our resources and focus our efforts, and it's a very coordinated way of how we do it. And then we also coordinate our media campaigns together with the signature events. We also structured our public education. We no longer do 15-minute talk, 30-minute talks. We all look at least a 90-minute session or a 2-hour session in order for us to make sure that the correct messages go down to the correct audience. And the results, in 2024, Lane Foundation did another survey, and there's a marked increase in the level of awareness, 70% of awareness of palliative care, and there was better outreach and deepened engagement across multiple platforms. The next slide I will share how the Live Well Festival 2025 expanded its outreach for the sector. So altogether, in terms of partners, speakers, and volunteers, we had about 13,000 footfall for the roadshow that we had at the shopping mall, 47 partners, 39 speakers, 69 volunteers, workshops, talks, and webinars that spread across 10 days over multiple venues, 30 sessions, 7 talks, 8 webinars, 15 workshops, 900 over participants, averaging 30 per session, 19 venues across Singapore. The feedback responses were very positive, and when we track the responses and participants, there is a high percentage of first-timer who comes and attend the talks and webinars. We're reaching out to new market, not the usual participants, and the media campaign that went along to promote the festival and palliative care itself. We have an outreach of 1.5 million above 40 years old, primarily the PMAPs. So this is an example of how curated events can expand outreach. Next slide. The next thing that we did was from factual resources, we went into storytelling. We had resources, but we wanted to create a hub, a credible national hub and shared languages. So in the past, we have resources curated by the doctors and nurses, social workers, but they were underutilized. Digital platforms had very low reach. In fact, our LinkedIn, we had the 10 fingers was enough for us as well. That was about 3 years ago. Resources do not leave an impression. There was duplication and lack of a nationwide coordinated approach towards resources. Data was not used, maximize its use, and the gaps and trends we could have been better collated and used for us to chart strategies and directions. So the change we did was to open source for partners to create links to our e-library. We are not selfish about it. Whoever comes to us, credit us, they can create a link to our resources. We cut down multiple partners trying to create the same resource. There was a consensus on the use of common terms and language. For example, compassionate discharge, we harmonize the processes and the procedures, and these are all on our website as well. In the e-library, we invite partners to co-create and co-share. Member organizations all participated across sectors, across settings, across profession, multidiscipline to do that. We boosted and tracked the traffic to our e-library. And that's important because we can't just do and produce and we do not know the usage. We boosted that traffic as well. We tapped on community resources, the assets of partners, and we also did a Singapore Deaf Literacy Index of the population, and we released the results and we made it open source as well. And the results of this change and the way we did things was an increase in the utilization. Over 2 financial years, we actually distributed an average about 80,000 printed copies of various resources over the 2 years, adding up to about 160,000. There was a growth in access and usage of our digital platforms. Our e-library now has a monthly organic search of about 2,300. The e-library is now recognized as the go-to platform for palliative care resources and information, and outreach initiatives are targeted, very targeted now. It's not random. It's to fill the gaps identified under the Deaf Literacy Index as well. And to just show how much we have grown in terms of our digital footprint, the next slide. We're happy to share. We are very happy actually with the numbers. As of today, our website, we have a following of about 4,500, Facebook 4,500, Instagram 6,100, LinkedIn we've built up about 600 plus. Our Hospice Link quarterly newsletter has a printed circulation of 7,005, digital about 2,200, mailing list of more than 7,700 of healthcare professionals, general public. So we actually tier the mailing list as well so that we target our messages to the right people, so we don't spam people as well. Okay, then the next strategy that we did, next slide, was to move from a specialist-centric services to involving primary care services. And this is really, we talk about building confidence and capabilities. In 2024-25, we did focus group discussion and the primary care landscape scan, quantitative survey as well. And the feedback from the family doctors, general practitioners, and the polyclinic doctors. Polyclinic doctors are the government clinics that you have the primary care doctors there. So they are the public service. General practitioners are in private service. And the feedback that came back, 3 things pop up. They lack confidence in the prognosis. They lack confidence with the controlled drugs administration. And they are not familiar with the referral process to palliative care for patients and family. So the change, what we did in order to build the confidence and capabilities, we raised charity dollars, and we now have what we call a primary care palliative champions PC2 training awards. We work with National University Singapore. We work with Nanyang University Singapore as well, the 2 medical schools where we fund part of the course for the graduate diploma in palliative medicine, and we fund part of the course for the master's program. We also work with 2 of our member organizations that provide training, where it's a short-term 2 days, half-day course. We will fund primary care doctors who wants to attend this. We want to remove as many barriers as possible. We also fund them to attend the Singapore Palliative Care Conference as well. The PC2 Telegram group is a Telegram group that was created for doctors to join. You can be a cardio, you can be a polyclinic doctor. You can just join the Telegram group. It is supported by a palliative care specialist, multidisciplinary team. And whatever questions that they pose, they are only one text away from a specialist team advice, including patients, whether are they ready to refer, prognosis, how to give quality of life, how to treat symptoms, how do they do the referral process, and they are just a text away from support. We are also in the process of setting up the Singapore Community Palliative Care Network, we call COMPACT, where we want doctors to join. Currently, Singapore Hospice Council membership is based on organization, it's not based on individuals. And therefore, we wanted the doctors to come on board. Capacity dashboard is something that the referral process is now much easier. They just need to key in the 6-digit postal code of a patient, and whichever hospices can take on that case will pop up as a green light. It's a traffic light system. Green meaning they can take, red light meaning that they cannot take. Amber is for compassionate discharge cases where patients go home to die. The results are not seen yet because this is something that will need a longer period before we can see the results itself. So with all this that we have done, the bulk of what we have done, it has led to the next slide. Early system level shifts, which we have noticed as well, and we are quite happy to report this. Earlier engagement with palliative care upstream. For example, Dementia SG has adopted palliative care approach to start off with that once they receive clients that they serve, which currently is not that case. Usually the referral comes much later. Stronger primary care and community roles, and definitely a more deaf and grief literate population. And with Compassionate Communities SG, it's a more coherent sector identity for Singapore Hospice Council to push public health approach and to demedicalize death and dying. And it's really about patients and family making informed choices. And all this boosts this. We expand entry points, we redefine roles, we change the norms and expectations, and all this enabled skills for us to scale up services as well. Next one. The next 12 to 24 months, what we want to do is continue to work with the founding stakeholders on their charters and action plans. We hold their hand, curate the program. We will also be advocating and publicizing COCO SG through social media stories and all that. And more importantly, we are going to be measuring the performance. We are now working towards a framework of how to measure the different stakeholders in the different sectors, and we're also partnering a university to do a intergeneration case study report. Because we just started, it is the right time for us to actually start tracking performances, successes, what are the key things that work, what doesn't work as well. Growing new stakeholders, we will still be part of the work, but it will not be our main focus. The main focus is to make sure those who are on board will do a good job and able to serve the people they serve better. And in closing, next slide. I just want the lessons that we pull from there of why community said yes and why it worked. It's really strong partnerships matter, trust matters, no wrong door matters, assurance of support, build confidence. They are not doing the walk alone, because this is what some of the questions that came back to us is that, you know, they are not sure how to start, they're not sure how to do it, they're not sure how to account to their board, to their leaders of success, what's their KPI, and that's quite very Singapore style, right? And the opportunity to improve capabilities for them to serve the people they serve better has also been a motivating factor for them to come on board this movement. And advocacy and shared responsibilities really connected the people purpose, and the systems. And one thing that we always tell people, Compassionate Community Singapore doesn't just belong to Singapore Hospice Council, it belongs to everyone. And with that, I will finish my section and then I'll take questions after all the other presentations. Thank you.
Thank you, Bihia. That was terrific. There's a lot of information there. I'm sure people will have a lot of questions, but we're keeping those questions to the end of the presentations. So thank you again, Bihia. That was great. A whirlwind tour of your social changes. Now we're going to hear from Noor Hisham. Noor Hisham from the National University Health System in Singapore, and he's going to tell us what he's been doing and his organization's been doing with respect to services redesign for public health palliative care. Noor Hisham, let's hear it.
Thank you. Okay, just check that everybody can see my slides. Okay, can. So I'm going to share a bit of piece of work what I do. I work with a public hospital within what we call a healthcare cluster, mainly in the western part of Singapore. But beyond this piece of work, I actually collaborate quite a fair bit with the community providers. And this is where my sharing is going to come from. And why is this important is because the way our healthcare system has been set up now is basically to work within zones so that we can support the community and to create the linkages between the health systems as well as social and community systems. So why is this important? Because as you heard from Bihia, we have reached a status of a super aged society in Singapore. And what does that really mean? It means that we really need to rethink about how our aging population are going to fit in terms of being as well as they can be as they age and as well as when they reach the need for palliative care services. So among some of the strategies that the Singapore government has looked at is really to look at how can we anchor aging in the community through supporting the seniors through various measures like aging actively, social connections, and to receive care within their communities. There has been a lot of inter-ministry effort to improve the physical living environment. So we are looking at how to make things elder-friendly, senior-friendly, and how do we get the seniors themselves to basically to age as actively as they can, while at the same time strengthening support for the seniors with care needs in the community. So no one really gets left behind. If you look at the details of this strategy, it is really looking at how can we reduce the disability in the later life, as well as to make them as independent as possible, so that as you can hear earlier from Biha's presentation that we want to help our seniors live well as to live well. And this is quite key as we have 1 in 4 citizens who will be aged 65 and above. And we don't want them to be really stuck in the chair, stuck in the bed, but be able to live as well as they can. However, recognizing that for some who have a disease burden, whether it's chronic illness has progressed to something that's more advanced, or someone who's developed a serious illness that needs more care, we can also look at how we can better support them in the community. So as part of the strategy that we have, historically we had senior activity centers to engage our seniors. However, that has seen a redesign in itself, where we have now shifted from activity centers to active aging centers, which technically means that doing more for our seniors so that they can be socially engaged, they can gain new skills, new activities, and be able to interact as well as make new friends within these centers. As you can see in the graph here, you can actually start to see how it has evolved over time. So the drastic change in terms of reducing the number of senior activity centers and pivoting them to become active agent centers, where you can see the sudden rise in the last 3 to 4 years. And that's quite key in terms of how we want to approach this, because we want to make sure that the centers in the community are better equipped and have been able to evolve to meet the needs of our aging seniors. So whether or not they're still fit, active, and independent, to those who need some help, as well as to look at those who have more functional disabilities and having caregivers to care for them, so that they can still remain within the space that they operationalize inside their own communities. And that's quite key, because we want to make sure that the connections they build over their adult years remain, and they can connect their neighbors as well as the others within the community that they live in. So in that itself, you can see that although the active aging centers can meet some of these needs. We also recognize that as we look at all these centers, we also find that actually there's a significant numbers of the different groups of people who will be presenting in some of these places. So you can see in the red box here, the Malay and the Indians who are the minorities in Singapore, they actually have a lot less functioning in terms of cognition, physical, and of course, in terms of those without any kind of disability. So although they may be actively engaged with life overall, they have other issues in terms of cognitive functioning as well as inclusion of major diseases as compared to the majority Chinese that is living in Singapore. So this has actually posed some potential challenges because the needs to be basically customized to meet the different ethnicities within Singapore. So you can also see in terms of the different age groups where the tiers are in terms of how it includes those with no major illnesses, with high functioning cognitively or physically, and those who are actively engaged. So as you get older, beyond the age of 85, you can start to see that they're less engaged in life. And then, of course, the amount of disability also increases as much as 70% among those aged 85 and above. So this poses some challenges because as we look at the active aging centers, we want to make sure that they can continue to meet the needs of our aging seniors. And the critical part about this is to make sure that every single person living within the community have their needs met through either cognitive engagements, physical activities, or even having some social interaction that can strengthen them within the community, as mentioned earlier, to help them age well within the community itself. Of course, as we do this, we also look as they develop all this physical decline, cognitive decline, how can we better create better support systems within the community to enable them to remain in the community and then, of course, to support their caregivers at the same time. So if we look at some of the challenges, we realized then that we wanted to look at how some of these centers can continue to meet the needs of the community at large. When I say community at large, we want to look at all the layers of the community from the different age groups to the different ethnic groups. And what we have also realized that as we look at the centers, we also realize that the minority groups are the ones that's least represented within these centers. And that creates a challenge because then the centers would no longer meet the needs of these minority groups, and we need to then challenge ourselves to look at what are the things that we need to look at to be able to enable them to be present in those places and to be able to achieve the original intent of aging well as they live within the community. So we start to ask questions about how do we engage the seniors from the minority groups to be active? What is missing in terms of what the centers are currently providing versus what they are already doing by themselves? Because just because they don't attend the center, we start to ask ourselves, is it because they're really doing some things on their own or within their own families or within their own social circles? Then we start to look about what are the needs? Are the needs of the aging minorities any different from the majority group? Is there anything that we need to attend to because of them being a minority? Is it something cultural? Is it something religious? And then we start to think about, do the aging seniors within the minority groups have desires to achieve something that is different from the majority group? And this sets us thinking about what are the potential things that we could look at to help to serve the aging population within the minority groups. And this is quite critical in terms of how we look at some of the things that we do. So one of the groups that I work with is a mosque within the northern part of Singapore, which is outside my hospital cluster. But again, to highlight that actually, although we work in sectors, sometimes we can cross sectors to ensure that we can meet the needs of the community in itself. So this particular mosque basically has a desire to see how it can meet the need of its population, its congregation that attends to the mosque. The mosque is Al Mutakin Mosque, located within the northern part of Singapore. We know traditionally the mosque have a role in terms of a place of worship where people will come, do their religious practices, and then they will leave. So that's always been the typical role of the mosque in the modern day. And we now start to look about how the mosque can now pivot to play a role as they start to see more aging seniors coming to the mosque. And typically when we have our religious practices in the mosque, when the sermons are having on, with the prayers, you can start to see that there are increasing number of aging seniors coming to the mosque to do their religious practices. And this started the mosque staff to start to think about how can I better serve our aging seniors that are coming to the mosque. They also have engaged some of these aging seniors and asking them about beyond coming to the mosque, do they go elsewhere? Do they go to the aging centers? Is there something else that they can do to support the seniors that is coming to the mosque. And it then started a whole series of work that we had from focus group with the congregation that comes to the mosque, engaging other centers within the vicinity of the mosque to try to understand in that sector, so that then we can look at what are the gaps. And that has led to a program that is now called Santunan Namas, which means really providing service that helps the aging community within that area of Singapore. And how they have actually established is they established that a lot of the aging seniors actually want to be able to continue their religious practices. So they've been coming to the mosque, but that's been only about as far as it goes. And as they age, they also have a lot of questions about how can they continue their religious practices as they have other conditions that develop that may affect their cognitive function as well as their physical function. And then it becomes a very real issue about, do they need to change their religious practices? And also have questions about spirituality that, of course, are best answered by the religious and faith leaders within the mosque. And beyond that, I think it becomes other questions about, if they cannot come to the mosque, then, how can they change the way they do things so that maybe they can better come to the mosque? It sets a lot of thinking in terms of, could we do more to help our seniors? And could we change what they are really going through today as they're aging in the community to help them? So as a result of that, what we have also established is that apart from religious guidance that's really ongoing, because they would already come to the mosque to get religious teachings, to get some education and clarification about religious practices, we could do more to customize some of these teachings that we have in the mosque, including the sermons, to make it more appropriate to answer the needs of the aging population. So for example, as they age, they start to realize that as they can't do their prayers in the normal way, they start to ask about how can they continue their practice to other means. So could they continue their prayers in a sitting position? Do they need to change how they do some of the ablution that they need to cleanse and purify themselves before doing their prayers? So the religious teachers have stepped out to basically give them guidance in terms of how to do this during some of these teachings that they have provided. And then of course, there's always the spiritual aspect, because some of them start to reflect about their past work, their past practices, and start to ask, could they have sinned? And would that now impact upon them as they start to age, and whether some of the challenges they face today are a result of some of their past sins. And of course, that kind of like help them in terms of processing how they're viewing their spiritual journey as they start to age. And then of course, some of them are seeking repentance and getting guidance about how can they get deliverance, right, for whatever else they have done in their younger days. And as they start to reflect in their older years, they want to see how they can better help themselves to be a better person. So leaders now come into play in terms of guiding them in terms of those religious aspects. Then if we think about all the health issues in terms of aging, there's of course all those clarifications about health and religious practices and how that can relate to one another in terms of, does the health really impede the religious practice? Do the medications they take, will they affect how they're going to practice their religion? And then this how we partner with the different specialties, the doctors, the nurses, to come to the mosque to provide some of this health education and health guidance alongside the faith leaders, so that now there is now this partnership between the faith leaders as well as the healthcare professionals. In this way, in this partnership, then we can strengthen in terms of how both the religion and the healthcare delivery can work alongside hand in hand. And along that lines, we also bring in our therapists to bring in concepts about why they need to have other activities to help them be able to continue their current religious practice. So I'll give you an example, right? So as they develop joint issues as they age, some of them have mobility issues. And this is where the therapist will say that, if you start to maintain your activities, you do some simple exercises, including stretching and whatnot, you can actually continue to deal with whatever religious practice that you have today. And you may potentially delay, mobility issues to a later stage, so that then they can continue to practice. And having the congregation come together and learn this together, it actually does help them to then see through peer support and then peer learning, how they can actually learn in terms of how they want to practice therapy exercises for their own purpose. As you can see, it's like we've even brought exercise sessions to the mosque, so that the elderly seniors can continue to exercise even after a release, and to remind them that the mosque will potentially be a place for them to exercise as they pursue their own religious needs. And then, of course, these are just short sessions for them to stretch, to move their joints, and then they can also see that, you know, the religion and the exercises that they do as they age can always be done together. And then, of course, we also want to encourage them to go beyond the mosque. So we actually try to connect them back to the active aging centers, which has a whole lot of other programs that helps to encourage them to exercise. So they could be going to the parks to take a walk, or they could have some other event that can actually encourage them to exercise through the invitation of different partners that the active aging centers actually involves. Of course, we also want them to volunteer, to give some time. And the idea of volunteering is to increase the volunteering spirit that also have social implications, because then they can connect with other seniors as well as connect with the youth who are coming to the mosque. And we also hope that as they volunteer and contribute their time, those social connections can actually help to bring them to bridge the age gap between the seniors and the youth. And again, as they work alongside the youth, that youthful energy sometimes rub off on our seniors, and then that creates a different spirit altogether that enables a very lively atmosphere for them. So as you can see in this picture, actually what you can see, they're actually distributing bags of food to the needy who sometimes come to the mosque. And that spirit of volunteerism, again, has a lot of positive effect on those who volunteer, and of course, all those who come to participate in such activities. And that's in a way to get them to actually really come out from where they would otherwise been, where they would basically say that they have nothing else to do, and then come forward to participate in the mosque. And we hope that by getting them to volunteer, they could potentially volunteer with other centers or other areas, so that actually they can be a lot more active in reaching out not only to their friends and neighbors, but of course to the wider community at large. We're also quite mindful that some of this volunteering may become very exclusive, so we actually try to partner them with other places, like you can see, partnering with the active aging centers, because then there will be a whole lot of other people from the other ethnic groups as well as the faith groups, so that they can now not only connect in a multi-religious way, but then again cross-learn as well as share practices about how they can age gracefully in time. And then, of course, in partnering with AACs, we also want to make sure that the activities that AACs can basically attract some of these seniors. And by allowing this connection with the AACs, I think what it enables is also to validate some of the things that AACs do, because they are unsure whether things like the activities is okay from a religious standpoint or cultural standpoint. So there's two parts to this, right? So while we work with the seniors, we are also working with the staff of the AAC so that they can have more customized approach to help the seniors from the minority groups, from a cultural, religious, and of course, in terms of meeting the needs of these minority groups. Of course, we also want to look at the kind of activities, and through partnership with the AACs, we can also share resources. Like, for example, in this picture, you can see they're doing some craft work, and actually by partnering with the AACs, some of the staff from the AACs actually come over to the mosque to basically encourage activities like craft work, for example, and sometimes also doing things like terrariums, anything that may actually interest to keep people active and to show them that they can pick up a new skill, a new hobby, and whatnot. Of course, what better way than to put all this today, right, than to put it on an online platform. So Santana Mas today has an online platform. You can Google it, you can find that platform. It's in English, and you can go and see what resources that's available on it. And this is basically to create a digital platform for the savvier seniors who can now navigate and then find resources for themselves. So it covers things like health, finance, housing, and whatnot. And basically is to ensure that as our seniors age, they also have resources that they can look through, that is basically curated by the builder of this website, so that actually they can now connect to different agencies that is now housed in this program. And because this program is basically intended to basically reconnect back the people from the Muslim community in Singapore to the larger community, having such resources is actually quite useful. And you can see one of the resources that we provide for are also the caregivers, because we also realize that some of these, although they may be aging, they actually have their caregivers with them. This could be a family caregiver, or it could also be a hired caregiver who's a domestic helper who's helping them in their day-to-day activities. And the rub of this is that actually the caregivers found that as they came to the mosque, they actually get support from other caregivers as well as support for themselves in terms of religious practice. And why is that important is because sometimes the caregivers found themselves too caught up in caregiving that they also forget about their own well-being, and coming to the mosque enables them to get that enlightenment, that support, as well as a means to basically in a way let off steam as they deal with the care of a senior with them at home. And of course, for some of them who are unable to actually come out to some of the religious talk, the platform that I talked about in this webpage actually allows them to look at some of the sessions that are actually live stream during the live event itself. So at least then you can attend some of these talks. And every quarter today, we're actually looking at doing a series of events to look at thematic things that is very agent focused and that of course provides supports for those who may be aging and may be facing the end of life. So if you want to look at this program, although successful in this mosque alone, has now expanded to include 3 other mosques. And the idea of it is to spread this, to scale it up so that we can support it, because we found that one, there was a positive impact on the congregation. 2, we were able to connect the congregation to the active aging centers and of course access those services that provided within the active aging center, and of course achieve the vision of aging well in Singapore, as well as planning for the end of life. So among some of the things that we do as part of our planning is of course to basically look at end of life planning tools, and some of these include doing a lasting power attorney, doing advanced care planning, and then of course doing legacy work so that they also start to think about what they want to leave behind for their loved ones, as well as to plan for their own funeral, which is important for some of them because they feel that they want to make sure that they have control about how their funerals are going to be held after they have passed on. So these are some of the things that I think we have done, and I think this still, I dare say, a work in progress. Because as we scale this, we are also learning a lot of things from our partners. We're also learning a lot from the mosque staff, as well as learning a lot from the seniors that are working with us in this and those that we are serving within the community. So I thought it's important to share about how we have pivoted from a mosque as a place of worship to a mosque that is partnering with active aging centers to help our seniors age well, and then of course to prepare them for the end of life when the time comes, because you can realize then that it doesn't only cover the physical aspects, the health aspect, but of course the spiritual and religious aspects as they approach the end of life, not only for the senior, but for their caregivers and their families as well. I would like to end there. Thank you very much.
All right. Thank you very, very much, Norishim. That's really great. It's one of the very few examples of public health palliative care in religious organizations. So it's very inspiring for all churches and temples as well as mosques, I think. The other interesting thing is this: the first really in-depth example of services redesign within a mosque that I've seen, and I think the importance for the Muslim community as a whole is that this is a very good example of leadership in public health palliative care, which is truly inspirational, very interesting. And again, I'm sure lots of people will have questions. I notice in the chat there's already a couple of questions, and we'll come back to those at the end of this session. So thank you again, Norishim.
Thank you.
Now we're going to hear from Emma Hodges from Public Health Palliative Care UK. Emma, take it away.
Thank you. So I'm going to go with a really practical tools-based approach. So if you want to do some service development and you don't quite know how to get the conversation started, then hopefully this will help you do that. So I'm going to talk about some of the pitfalls in practice by sharing some examples of service redesign that I've been involved in over many years. I'm going to talk about some of the challenges around that. I'm going to put a plea out for ensuring workforce and service redesign are seen as hand in hand. I'm going to talk a little bit about the agenda versus agenda-less approach to community development, which can make it quite tricky, but I've got a way around that, I think. And talk about a tool that has helped me move my service redesign practice forward, and it's available for anybody to have a play with and use. But I'm going to go back, and I'm probably going back about 20 years to this first example of service redesign. Now, bear with me, I know it's about maternity and we're talking about public health palliative care, but this is about method. this was brilliant. We had this really big wall in an acute hospital in Stoke-on-Trent in Staffordshire, and we had a specialist brought in, transformation director type person, and he put brown paper across this long wall, and we had sticky notes, and we were putting up that, you know, this is going to happen and then this, and we were process mapping the whole of a maternity service redesign pathway, and it felt fantastic. But when I look back, I was there representing the workforce. I was assistant director of HR. I probably had 2 of my 3 children by then, but all of that knowledge has been a pregnant woman went out my head. I was there with my professional hat on. We had 1 medical consultant, maybe 2 midwives, and we had the audacity, that 5 of us, to think that we could completely redo a care pathway for maternity service redesign. There were 5 of us in that room. It felt great, but actually knowing what we know now, well, where did that piece of work start and finish? And where was the voices of pregnant women? And where was the voices of the administrators that we were redesigning their roles? Because what I was sort of doing was, right, so we're going to have an admin person do that, and that's going to take how long? 5 minutes? Yeah, sure, 5 minutes for that task. So by the end, I could calculate all of those tasks and decide how many admin, maternity support workers and midwives we needed for the population. Love doing that sort of thing. Complete waste of time, and won't have made the difference that we would have wanted to when we think what we know now. The next one was really curious. So this was an orthopaedics care pathway design, part of a care pathway design project across this acute hospital. And actually, as the workforce lead, I wasn't in the room. Neither were any of the other people doing the job. The only people in the room were the medical consultants, the orthopaedic consultants, and they designed what they said was a gold standard care pathway for their patients. The issue with the gold standard care pathway was that no parameters were put in place and the hospital couldn't afford the gold standard. So we had taken this group of people, inspired them to come up with something wonderful, and then said, sorry, we can't afford it. Deciding where the pathway was going to start and finish, well, it started when they got on their books and finished when they discharged them. And the consultants would say, well, we don't like discharging our patients because we don't trust the community services to have the same care for the rehabilitation post-surgery. But actually, we're not going to invite them in the room either. So as an example of service redesign, and these 2 examples are not unusual within health service design projects. Again, a bit of a mystery not being in the room, but the outcomes of that were also a complete waste of time and actually demoralising to the consultants that put the time in for the service. So one of the things that I've pleaded for ever since getting involved in service redesign with a HR hat on 20 years ago was that service redesign is not an island, and any service redesign is going to involve changes to role design. It's going to involve new roles, new workforce parameters, new conversations with people. And if the people doing the role aren't in the room, you're just going to make it harder to implement service redesign changes. So engaging early, involving really meaningfully, and being mindful of active institutional work. Now, institutional work is part of a theory under organisational institutionalism, which was the theory I did my doctorate around. I was looking at dementia in hospices. And in institutional work, you have people that are there to maintain the status quo. And they do so by stealth, by changing the words on processes and referral pathways. And it's really interesting when you start to spot it. So being aware of the saboteurs within organisational change, or the maintainers within organisational change. And of course, we are on a change journey, and that needs to be handled sensitively. So if you're thinking about service redesign, please realise that we're talking about workforce redesign at exactly the same time. So when I think coming forwards into the palliative care world about 15 years ago, and thinking about what does service redesign look like now, particularly with the public health lens, actually the Ottawa Charter tells us how to do service redesign. It tells us the principles that we should be looking at. Of course, we should be strengthening community action, developing personal skills, advocating, mediating and enabling citizens to be able to do more, as well as different roles within the workforce, creating supportive environments, and reorientating health services. So when I think about the Ottawa Charter and the opportunity missed doing maternity service redesign, it could have been very, very different for the experiences of those women in that particular county. I then came across Cormac Russell. He is charismatic, engaging, tells wonderful stories about community. And if you're not familiar with him, then he's got lots of TED Talks out there. But I was really challenged by the fact that we're told to start with a blank sheet of paper when we're doing community service redesign. We should be dealing with the things that matter to the community. Well, every time I turned up to a community meeting with a hospice lanyard around my neck, I clearly had an agenda. Every time I introduced myself with wherever I work for, I clearly have an agenda. I'm going to talk about death and dying, because that's the lanyard around my neck, that's the role. So I found it really, really challenging to think about how do we do service redesign in an agendaless way. Because that's what Cormac Russell says, but actually you can't. So I'm going to cover that in the next slide. If we look at asset-based service redesign or community-based service redesign, which I sort of call it, then we need to be aware of the start and finish of a service. We need to think about the Ottawa Principles, and we've got to be clear about who needs to be involved and be honest about parameters. Don't put people in a room and then say you can't afford it. If there is a parameter about the service must take place in this way or in this space or with these people or with this budget, let's just be honest about that up front with whoever's in the room, including members of the community. Cormac Russell talks about 3 lanes. So he talks about, you know, the things that people should be doing by us, the community doing it by themselves, with us, as with services, and for us in terms of what services have to do for people. And I had that, and that was sort of buzzing around my head, and then looking at the new essentials of palliative care, and actually started to use the new essentials as a service redesign process. Worked with a neighbouring hospice where we were able to say, well, what could we shift from specialist to generalist or generalist to community, because the NHS was talking about left shift. So it's like, what can we just shift along a little bit? And that was quite helpful. But again, we didn't really have the right people or all of the right people in the room. But let me come back to this concept of agenda. The agenda setting is really critical when we're doing service redesign. If we want to invite people into the room, they need to know what the agenda is. But how we do that is equally important. So picking up on the visit to the mosque in Singapore and seeing the strength of the community and what they were building on. I'm doing some work in Birmingham with the Gurdwara, and it really helped me think about how to pitch that agenda. So being able to say to the leaders within this Gurdwara that, you know, we know that you're a really strong connected community. We know that you've got fantastic strengths as a community. And according to our data, we know that the experiences some of your residents have relating to death, dying, loss and caregiving are not as good as other parts of the city, and we really want to explore what's going on there and what might we be able to do together. So being really clear. The other thing with the Gurdwara was recognising that there were things they were concerned about too. So, you know, saying something like, we're concerned about the experiences relating to death, dying, loss and caregiving, and we want to talk about this. And there may be concerns about health and wellbeing that are worrying you more, and we want to understand these too. So we're trying to create a mutual agenda here. This is what we're coming to the table to talk about, and we want to hear what your other concerns are. And in this Gurdwara, they are concerned about isolation, they're concerned about death, dying, grief, access to services, and they're concerned about women's mental health and domestic violence. So we've been able to open up conversations and think about who else can we bring into the conversation to amplify and equip the skills that the community already has. So thank you to my colleagues from Singapore for helping me shape how to do that in my head. So a little while ago, I was sat in a room doing a project on integrated neighbourhood teams again in Birmingham, and we got colleagues around the table, and they were trying to start to imagine what an integrated neighbourhood team could be like if they were bringing community assets to the table, some of the clubs, groups and associations. And that was what I was there for, really, to advocate a compassionate community or an asset-based approach to integrated neighbourhood team. So as I often do, I'm there and I find a flip chart and I find a piece of paper and I've got Cormac Russell's 3 lanes in my head, and bring together this model. And this is the tool that I'm now using in service redesign projects that I'm involved in. So taking Cormac's 3 lanes, it was too simplistic. We needed to break the middle lane into 2 parts. And we also needed to remind ourselves that we need to think about who isn't in the room and think about belonging and inclusivity. So this model, you do it in order of these boxes. So you start with box 1. What are communities doing by themselves? Doing the treasure mapping, what is available? What are people really strong at? Then building that a little bit with what could communities do a little bit more of if they had training and support. And I've got a case study to demonstrate how this worked as an online webinar in practice. And another one that was a face-to-face workshop. Once you've started to think about what we can add to a community, then we can start to think about what we do together. So what's a partnership approach look like, as opposed to an equipping or an amplifying or skilling up? I think those are 2 distinct different sections of a service redesign approach, hence adapting Cormac's 3 lanes. And then, of course, there will be things that services have to do. So let's be honest about that too. So by working round in this order, you start to create some creative thinking and energy. And if you've got the right mix of people in the room, you can start to see services change in front of your eyes. It was quite incredible trying this service out with the case study I'm going to share next. But just to point out, when you talked about this model in Japan towards the end of 2023, the issue of the word belonging was a discussion that we had, that the word belonging can sound like somebody exclusively belongs to one community and not another. So I'll sometimes put the word equity in the middle of the box, or inclusion in the middle of the box. Whatever word reminds you, if you're using this tool, that you've got to think about who's not there. You've got to think about the other voices. And so, but if the word belonging is problematic, if it creates more exclusion than inclusion, then it doesn't have to be that word. But it was an interesting discussion about this concept of belonging to one community, meaning you don't belong to another. So I'm going to show you, just talk through a case study. Now, I'm going to apologise for the amount of words on the next 4 slides, but this is the actual output from the workshop, so it would be remiss to edit that down. So this was a Somali community with adult social care. So it was an online workshop. We had members of the Somali community, particularly people that were informal community leaders, and some charity workers within the Somali community. And I had adult social care people, so social workers, and other people working within that field. And we did this as a webinar with a colleague, Balvinda Kaur, that I was doing this piece of work with. And we started with box 1, what's the community already doing? And it's just, well, it's wonderful. And to many of you, none of this will be a surprise. The community felt that they were connected by language. They had a common cultural understanding. They had knowledge of different generations and experience of being the first wave of refugees. They understood the changes in education and economics of transitioning from Somalia to the UK. They understood the local issues such as welfare, housing, supporting people through education and domestic violence. The mosque was a central focus. It saw people regularly and spotted who wasn't attending, and they had celebrations and other ceremonies and services that brought people together. And on a Friday, if somebody wasn't attending, the community would spot that and check up on people, and from that start to arrange hospital visiting or whatever support that person needed during the times that they were struggling. Food is used to create togetherness, to support new mums. They've got a range of community activities happening in the mosque, and religious festivals. Everybody knows each other. It's family orientated. And what was really, really interesting was by the time they seek support, they've already utilised what's around them. And that was one of the most powerful sentences in this particular first workshop. When they looked for support, they'd already used their community assets. They needed something different from the system. So what was really interesting then was when we were thinking about what could the community do a little bit more of. So the community can still own this stuff, but they need to understand a little bit more about something rather than it still being a service. And what they really wanted was to raise the trust and connections within the communities. They wanted a better understanding of what services can offer. They wanted their informal community leaders and their formal community leaders to work together with adult social care to understand the issues that they could navigate. They didn't want a leaflet from adult social care or a conversation. They wanted to talk together and understand how to navigate some of the support that was available. They wanted to skill up their word of mouth support networks on key health and social care issues. So they wanted their natural networks to know more about cancer screening, menopause awareness, mental health, domestic violence. By skilling up their informal networks, they felt that they could do more together. And that's what they wanted adult social care to provide for them. They wanted to build confidence. They wanted to create bridges between the community leaders and other parts of the service system. They wanted to improve accessibility of information, and they wanted more multicultural understanding for young people who are querying identity and traditions. That was something that they felt they needed to do with people from adult social care that understood the UK systems more effectively, but could understand multiculturalism. And they wanted their informal health champions from the community to be involved in anything to do with the benefit of community, not being just for service providers. So they could talk about these wonderful people in their community that just needed a bit more knowledge and how much that would help. Then we were talking about what could be done in partnership, and again, they wanted the community coordinators to be able to create connections. They didn't want there to be this like void between where the community coordinators finished and professionals started. They wanted more of a relationship and trust building, spending more time together, talking about barriers and challenges collaboratively, to be able to talk about the things that were going on in the community and what might be helpful for them. They wanted health and care staff to spend more time in the community also. You know, they wanted people to go out and spend time with them and understand the community more effectively. They wanted to help with breaking down some of the barriers, building some of the trust. And they particularly said they wanted to engage closely on any digital development. And I've just heard of a digital development that's just been taken offline because they used a technical translation tool and didn't check it back with the community. And those tools have now had to be removed. So we have to be really careful with this. And they said they do not want services to take over. They want communities to maintain the connections with each other. And not rely on a service to take over. And then as service providers in adult social care in the UK, there are statutory requirements that they have to follow through. So, you know, some of that crisis management, etc., and commissioning care packages they needed to work through. Case study 2 is a children's hospice. This happened very, very differently. So, you know, post-it notes, same boxes. And as a result of this, there's been a new role being brought in to develop more community assets because of the isolation. They were able to use these sorts of tools to get the conversations going in terms of treasure mapping and some of these conversational prompts. So in summary, what we are able to do by using a really, really simple tool is recognise that traditional health service models of redesign just aren't working. They won't work for any healthcare system, really. We've got the solutions in the Ottawa Charter. A simple tool provides an engaging way that we can shift from a service mindset to a community mindset, but we also always have to be thinking that whatever happens is limited by who is in the room. So I hope that gives you a tool that you can go and play with, you can use, you can try it internally, you can use it with partners as a way of prompting some creative conversations around service redesign. So thank you very much for listening to that, and I hope it gives a simple and practical approach to take forward.
It does. Thank you very much, Emma. That was really great.
Thanks, Alan.
The really practical examples that you give, not just in palliative care, but in other areas of health. And you're able to sort of articulate the sort of simple ideas involved in services redesign that allows us to sort of think more kind of very clearly about what the practical steps might be in reorienting our health and social care services. So thank you for that. That was really great. So I think now we can open this up for questions. If you would like to come on, you can ask your question directly. We do have some earlier questions from the chat box, I think. Somebody did ask Norisham a question, I think, about how you get volunteers involved. Where's that chat box there?
I could still answer about how we got volunteers involved. Well, actually, it's like most organizations, actually, we always look at reaching out to people who are willing to contribute. In the mosque, I think in most of places of religious worship that I've worked in Singapore, there are always people who are willing to give back to the community or to the church or the temple or the mosque. And actually, sometimes they come forward to say that, is there anything that we could do or contribute? And that's where actually we basically engage them and try to find out, do they have any specific areas in mind that they want to volunteer in? Or are they asking us whether they are whether we have programs that they can contribute in because they just feel that they can have some time to give to. So what we try to do is in the mosque that I volunteer with, actually also volunteer with some of the mosques, it's really about then finding people who can galvanize these volunteers to look what can be done. And in the Singapore setting, some of these volunteers tend to be the retirees. So they've retired, they find that they want to continue to contribute, and they should offer to do things that within their own skill set. So we have got volunteers who do like sometimes a bit of gardening work because they have skills in gardening. Some are offering to do simple jobs like if you have a leaky faucet, we can fix it. Some lights that's a bit faulty, they can fix it. But in the bigger scheme of things, what we wanted to do is beyond contributing in this way. We wanted to see how can we galvanize all these people to work towards getting other seniors on board and reaching out to other seniors. And that takes a bit of effort. And what I shared with my mosque leaders was about how we borrowed some of the examples from St. Christopher's Hospice, whereby they start to invest in programs for the volunteers, where they basically teach them some of the things that can help them to engage others. So it could be communication skills, how to interact with others, and then how to respond to people's when they are engaging with them. And I think that was quite useful because in a way it taught us that actually that if we started to invest in some of our volunteers, the pool of volunteers will get bigger because they feel that they have some satisfaction in the work that they do. And of course, as they do their outreach, we found that others may also be interested in what they are doing and they want to come on board to similarly contribute to others. Of course, beyond that, I think in terms of getting the volunteers, is we also know that sometimes volunteers also have their own commitments. So we also work along the lines of creating schedules so that they also know ahead of time what are the events that is happening. So for example, in this current month of Ramadan, we actually engage quite a lot of volunteers to reach out to the community, to some of these seniors who can't come to the mosque, to distribute things like porridge, to basically to look at their own well-being because sometimes they have additional needs because of the fasting month. And in that way, then we are able to engage the community. So because in the Singapore's multi-faith nature, we actually have sometimes even the church groups and the Buddhist groups coming to the mosque to say that, look, our volunteers also want to work with your volunteers. And then it starts to grow from there in terms of how that interfaith collaboration then starts to work. And then for those who are working with the active aging centers, I think what we try to do is to see that if there are any seniors there, they don't have to come out of their way to come to the mosque to collect, like for example, porridge for the breaking of fast. We will get our volunteers to go to the centers to distribute, and the food that we distribute, the porridge that we distribute, is not restricted to the Muslims. We share with everybody who is coming to the center, and in that way, actually create a lot of goodwill between the different faiths as well as among the different volunteers. I hope that helps to get and show how we actually try to encourage volunteers to come to us as well as to basically to grow the pool of volunteers with us. Thank you.
Thank you, Norisham. if anybody else has any questions, please please raise your hand using the raise facility there. And Emma has added a comment adding to what Norisham has said. It's worth reading. But before I move
Alan,
on to...
I'm sorry, you have one question in question and answer. What is the challenge in your hospital to integrate palliative care into oncology?
Okay.
But I don't know who. So, Leo, I don't know who you want to answer this question, but if any of you would like to answer.
Could you ask that question again, please?
What is the challenge in your hospital to integrate palliative care into oncology?
Not sure about that question. None of the speakers are from hospitals.
Nope.
Perhaps
Doctor, maybe I could just add a little bit to that. In the Singapore context, Dr. Noor Hisham is working in an acute hospital. But under the Singapore Hospice Council, it is an umbrella body, and we do have oncologists, palliative care doctors who are involved in the entire fraternity. So as an umbrella body, we actually cut across that. So in terms of the integration, the oncologist doctors who are involved in end-of-life matters are very much part of the palliative care fraternity in Singapore. So that's in the bigger landscape. So maybe Dr. Noor Hisham will add on as a practicing doctor in an acute hospital.
Yeah, so within my hospital cluster system, what we try to do is basically to not only focus on oncology, but also deal with our other colleagues working in cardiology, renal, respiratory, and hepatometabolic, as well as the surgeons, to think about early palliative care. I think if you heard earlier, Bia was sharing about how referrals are coming in late, people are thinking about palliative quite late. So what we are trying to do today is not about getting the specialists in palliative care to do the work, but to create awareness that everyone who's delivering healthcare in the hospital has a role to play in delivering palliative care. So what we do is we've done roadshows as well as talks in the different departments to basically share them about what are the roles within the specialty. So what we do is we partner with, for example, in the oncology, a fellow oncologist who has some interest in palliative care, and we basically work with this person to basically share within the Department of Oncology about what are the things that we can do as an oncologist to deliver palliative care in the day-to-day work. So it may not be relevant to all patients, but it starts them to think about when can I start to initiate palliative care. And then basically what we are trying to do is to basically work with fellow oncologists to say that if a fellow oncologist can do it, then can the other fellow oncologists working in the department look about spreading their work among themselves to do it so that they can really start thinking about early palliative care in the work of treating their patients on active treatments and those who are moving towards palliative treatment, and then of course best supportive care. So in that way, we are actually trying to shift it to say that it is not only the work of the palliative care physicians, but also every other physician within the hospital can play a role in this. And where is the results of that? Today, we are really looking at even the residents who are really thinking about when they can really start conversations about care planning, conversations about palliative care with their own patients as they're coming in acute crisis, and then start to plan about if this thing doesn't well, have a serious illness conversation with them, and then start to shift the care about what's important to them. And then, when there are difficult symptoms, complex conversations, then they will visit the palliative care team. So, I mean, there is really a limited success now. I say limited because it's still work in progress. We're also seeing colleagues in surgery, colleagues in cardiology who are really looking at, the heart failure groups, where they could really start to think about initiating early palliative care, and then, working with our community partners in the home hospice provider setting to see how they can continue to partner the care as they're transitioning from treatment in the hospital towards care in the community, and then eventually towards end-of-life care. Work in progress, but I think because our intent is to really educate our colleagues about how palliative care can be considered as they are really treating their patients before they start to treat and land in a major crisis and then nobody is prepared to really talk about end-of-life care as well as end-of-life planning. So that's the work we're doing so far in terms of integrating palliative care, not into oncology alone, but into the different specialties that we have, patients who develop organ failures and advanced illnesses. Thanks.
So just to add on to Dr. Noor Hisham, so there is work being done with NNI, Singapore Heart Centre, different specialty. This work is not just helmed by Singapore Hospice Council and the palliative care consultants. Philanthropies foundation like Lin Foundation is also upstreaming palliative care as an approach that should be adopted by the different disciplines of the medical side. So it's all work in progress. Beyond just the community engagement, public health approach, the other disciplines are all, there's a landscape push for palliative care to be upstream in all the different sectors. Yeah, hope that answers the question.
Thank you, Bahia. Any other questions or comments? Please raise your hand so we can see you. Norishim, have you thought about partnering or mentoring other mosques within Singapore, inviting them to see what you're doing and creating a partnership with them? I realize that it's a project in progress, but I wonder whether it occurred to you to spread the work that you're doing.
So I'm glad to say that because the mosque also divided into clusters. So the North cluster is taking it up and scaling it up within the North cluster. Recently, last month, we actually started work with the Eastern cluster. So I'm in conversation with the Western cluster, which is where I work. It's still work in progress, but you're right. I really started to think about it and starting to understand the different challenges in the different classes. But it's still work in progress. I hope to be able to update you in due course about how it goes within the Western cluster, but at least we've gone beyond the North and gone to the East now. So we're now looking at the West, and one more cluster that's left is our Central and South cluster. So hopefully, maybe, I don't know, in the next year or so, maybe we have started planting more seeds in the West and the Central cluster, and then we can update more about how things are evolving within those areas.
Very interesting.
Sorry, just to add on as well, Singapore Hospice Council last year did a leaders forum with Muslim leaders. So the MUIS, which is the organization looking after the mosques in Singapore, the leadership was also there. Different mosque leaders were also there as well. Indian Muslims were also represented as well. And that's a precursor for us to actually then pursue the topic of compassionate communities, SG, public health approach, and how mosques can come in. We have shared our resources with the mosques as well. We have done palliative care 101 sessions. Dr. Noor Hisham helms it, same language, and it's much easier to converse as well with the mosque leaders and their volunteers. So it is the mosque is a big piece of work under Singapore Hospice Council as well. So we work with MUIS, we work with mosque leaders, and we work with the stat board managing the mosque as well. So that is a piece of work that we started embarking on last year. And we hope to see more results and more mosques coming on board Compassionate Communities SG. Yeah.
Very interesting to hear. You're doing similar work with Christian churches?
Yes, we have done with churches. The Colossian Mission Singapore, the Catholics, is on board the Compassionate Community SG, and they are garnering the Catholics in terms of the movement, and they already have their charter in place. They are now developing the action plan. In fact, this coming Saturday, I'm doing one palliative care 101 session with them. So that is the Catholics, and we also go into the other churches to actually run palliative care 101 to share the resources. Some of them are on board our community signposts. So the community signpost is a lower hanging fruit than Compassionate Communities SG. So we train the staff and the volunteers, and then they basically is a point where we put our resources there, and the congregation can actually assess that. And once they come across a case where it's a bit more complex, they can accelerate the case through Singapore Hospice Council, and then we can direct that to the specialist team or to the community where the patient and family is, in order to give them that kind of help. So we are reaching out to churches, mosques, and this year we'll be focusing on the Chinese community, the temples, and also the Hindus, the Indian community. So Singapore is multi-race, so we're not homogeneous. So, but our resources is actually translated into 4 languages for the printed materials, and 7 languages on the digital e-library. So that includes the hired caregivers, like those from Myanmar, Philippines, and Indonesia. So our resources are all translated that way so that people can access it. So it is more complex. We are small, but we have more diversity, and whatever we do, we need to multiply that by 4 times. Yeah, because of the different ethnic groups. Yeah.
Yes, yeah, I understand. I appreciate that. Because we should ask this question continually with the Jewish community and with the Buddhist community, and it just keeps going, doesn't it? But I understand you're a national organization, so I know that you're working through this kind of stuff pretty systematically. Are there any other final questions? Otherwise, it just remains for me to thank you all for participating today. We've had some great speakers. There's a lot to think about. And all 3 speakers have given us inspiring theoretical and practice points to think about in our own national and regional contexts. So going forward, I think it's very, very important to remember that the public health approach to palliative care is not just compassionate communities or compassionate cities. It's also services redesign. It's also public education and public literacy and end-of-life care. It's also health and civic policy development. It's a broad range of strategies that we use to enhance health and well-being at the end of life. And today's speakers are very, very good examples of services redesign in the service of those goals in public health and palliative care. So thank you all for participating today, and thank you again to each of the speakers, Bahia, Emma, Norisham, for wonderful talks this morning. I'm sure we've all gotten a lot out of it. Thank you very much, and thank you all for participating.
Thanks.
Thank
Bye,
you.
everybody. Thanks.
Thank you. Bye.
Thanks. Bye.